So that should be recorded. Great. And then I'll just do slideshow mode. Brilliant. Over to you. Thank you.
Wonderful, thank you. So, just a little bit of background. So, yeah, I'm a consultant upper GI surgeon, and I've been working on the BOSS study now. My connection started back in 2014 when I was doing research with Hugh Barr. But Hugh Barr had set up this big trial based from Gloucester that's been running for many, many years, and we'll tell you the story of that together, myself and Catherine. I will give very much the sort of clinical and scientific perspective and tell the story of the trial, really in terms of how it might be presented at a conference where we just focus on the results. But there's quite a lot more to a trial than that in terms of the practicalities of setting up and running a trial. And so Catherine will give you the real story behind the trial after that. If we can go next slide, please. So potentially a mixed audience. So in terms of the key terms that I'm going to be using for some of the conditions we're talking about today, just to understand what Barrett's esophagus is. Barrett's esophagus is the name for a change in the cell type lining the esophagus. So it's a condition that doesn't cause any symptoms or any direct harm itself. But that change in the cell type lining the esophagus, we know, puts people at a slightly higher risk of developing esophageal cancer. Exactly how high that risk is something that's been the subject of debate and something that is one of the important measures in our trial. But this is a condition that can be seen when we look with a telescope. When somebody has an endoscopy, a telescope procedure to look into the esophagus, we can see this change in the lining of the esophagus, and we know that that's a potential sign that people are at higher risk of getting esophageal cancer. The other term that I'm going to be using today is dysplasia. So that's a further abnormality. So if somebody has Barrett's esophagus, those cells, when we look at them under the microscope, can have different appearances. And some of those appearances, what we call dysplasia, tells us that people are at an even further increased risk of developing cancer. So if somebody is found to have dysplasia in their Barrett's esophagus, that's an important finding and affects our treatment of people with dysplasia. I'm also going to talk about surveillance endoscopy. And what we mean by that is a camera procedure, an endoscopy, a telescope procedure performed at regular intervals. And in this case, that's to look into the esophagus. And that's really the core of what we're talking about today. Next slide, please. Thank you. So for Barrett's esophagus, the concept of endoscopic surveillance, so those regular examinations with a telescope, it seems logical and it seems obvious. There is a visible, potentially precancerous lesion there. It's something we can see with a telescope. We know that we're able to pick up dysplasia, and that when we do pick up dysplasia, it's a sign that patients can be kept either under closer surveillance or offered treatment at that stage to try to prevent a cancer. So it seems like the obvious thing to do, and a logical decision would be to offer people regular examinations to have a look into their esophagus and keep an eye on their Barrett's and see if there's any progress. Next slide, please. If we pick it up at an early stage, people have better outcomes. That much is known and that much is clear. So we can treat dysplasia, and the idea of that would be to prevent people from getting cancer. Or if we detect cancer at an early stage, we know that people's outcomes are better. For all of us who work in healthcare, we're also very affected by our own experiences and clinical anecdotes. And we know that we can think of individual cases where maybe we've picked up a cancer early, somebody's had a good outcome. And of course, that's what we're all here to do. And we all feel like we're making a difference. And that's the key thing. However, next slide, please.
It's taking a moment. Don't know why. Okay.
So we're all subject to those sorts of stories and experiences, and can think of instances where we've picked up cases and we feel like we've saved somebody's life. But on a wider scale, the big question is, are we really making a difference? Because we know that with surveillance endoscopy, there are lots of challenges. There are lots of things that mean it might not be a very effective process. So first of all, dysplasia, those cell changes that are really the key indicator that somebody's at increased risk, it can be missed. It's something that isn't easy to see when you look with a telescope, and in many cases is only picked up on biopsies. So what we do with a surveillance endoscopy is we take a whole series of random biopsies every couple of centimeters up and down the esophagus, with the hope that that will identify any patches of dysplasia that might be present. However, we know that dysplasia can be missed with this. First of all, we can't see it. And second of all, we're only sampling a tiny fraction of the mucosa with those biopsies. And studies that have looked at whether people closely adhere to that protocol, the idea that you have to take many, many biopsies during this endoscopy, real world studies suggest that people only adhere to that in about half of cases. And there are lots of reasons why that might be the case. People are time pressured when doing the endoscopies. Patients might be uncomfortable, and quite reasonably, endoscopists want to limit the duration of the procedure so that patients don't experience discomfort during the procedure. But for both of these reasons, it means that we don't detect dysplasia sometimes when it is present. We also know that even when we do get the biopsies and show it to the pathologists, they don't necessarily agree. So there can be differing views and different interpretation of the same slide. And some studies have shown really quite significant discrepancies between pathology reporting of low-grade dysplasia particularly. Next slide, please. Over the last 20 to 30 years, there's been a clear trend to reduce endoscopic surveillance. So although I introduced it at the start and said that it seems obvious, it seems like the logical thing to do. You have a precancerous lesion, we can look at it. Why don't we look at it very often? So when people first offered surveillance, the plan was to do it every year, and people would have an examination once a year. That had reduced to twice yearly by the time of the 2005 BSG guidance, and when the trial was started. But in the meantime, actually, further data has come through that's shown that the risk posed by Barrett's esophagus is actually really quite low. So for a patient with Barrett's esophagus, their absolute risk of developing esophageal adenocarcinoma is about 0.1 to 0.3% per year. So really a very small risk. And of all of the patients who have a diagnosis of esophageal adenocarcinoma, only 11.8% of those have a prior diagnosis of Barrett's esophagus, even though we know that Barrett's is quite a highly prevalent condition, suggesting that any surveillance that we might be doing isn't impacting significantly on outcomes from esophageal cancer. There is some evidence that looks at the benefits of surveillance, but this comes from a number of observational and cohort studies. There's no randomized controlled trial data, and that evidence is somewhat conflicting and doesn't give a clear picture of whether surveillance is making a difference or not. So over the last 20 years, a clear trend to reduce surveillance and increase the intervals between surveillance. So current guidance suggesting for non-dysplastic Barrett's intervals of up to 5 years, in fact, between endoscopies. Next slide, please. So in the presence of this conflicting and weak data, uncertainty and a changing landscape, what we need is a trial. Only a randomized controlled trial can really answer those questions. And this was something that was recognized in the early 2000s or early to mid 2000s. And so the BOSS study, the Barrett's esophagus surveillance study, was the first randomized controlled trial to assess the impact of surveillance. That was started here with Hugh Barr, Professor Barr, as the chief investigator. And it was recognized at the time that to try to answer this question, we'd need a large cohort involving many, many patients across many, many centers and a long follow-up, something that's going to involve an awful lot of resource. And Catherine can tell a little bit more of that story as we come on to it. Next slide, please. So how was the trial set up? So this is a randomized controlled trial. involving 109 centres across the UK, with a follow-up for a minimum of 10 years. The population included were any adult patients with Barrett's esophagus, and in terms of defining that Barrett's esophagus, they had to have at least 1 centimetre of circumferential or at least 2 centimetres of non-circumferential Barrett's esophagus to be included. The intervention arm received 2 yearly endoscopic surveillance in line with the guidance that was present in the UK at the time. The control arm didn't get any scheduled endoscopies. However, they were counselled clearly about the potential risks, and they were told to get in touch if they had any of a range of alarm symptoms that might suggest esophageal cancer. So any patient who was in that control arm, or what we referred to as the at-need arm, would be offered an endoscopy if they developed symptoms. Next slide, please. Our primary outcome measures, so the most important outcome and the key thing that we were powered to detect, was overall survival. So what we wanted to know was, did regular surveillance endoscopy reduce the number of deaths in that arm? And that was death from any cause, not just death from esophageal adenocarcinoma. There were a number of really important secondary outcomes that we looked at. So cancer-specific survival, so death from any type of cancer, time to a diagnosis of esophageal adenocarcinoma, the stage of cancer at diagnosis. It would be an important finding if we found that we were detecting cancers without surveillance, but only those at a very late stage where the prognosis was poor. That would be a really significant outcome. We also wanted to measure the frequency of endoscopy. It would seem very likely that those people who are getting scheduled endoscopy would have more endoscopies, but of course the at-need arm can have endoscopies as well, and so that's an important outcome for us. And then to look at adverse events. What are the consequences of having an endoscopy? Are there any complications or adverse incidents from having an endoscopy? Next slide, please. So the trial recruited successfully between 2009 and 2011. Around 3,500 patients were successfully randomized into the trial. And the last scheduled endoscopy was completed in January 2022. Our follow-up was completed in March 2024, giving us a median follow-up time of 12.8 years for these patients. Next slide, please. So the consort diagram, it's a busy slide, but I think probably the key points here are the, if you press on again, Emma, I think there's some red circles that might appear if you just press the next arrow. Thank you. Yeah, so the key points really, you can see there's around 1,700 patients in each arm. There was a difference in the number of patients completing the study between the two arms. And as you might expect, there were more patients who were offered regular endoscopy that did not complete the study. And it may be that that's because as people got older or developed other health conditions or weren't fit enough to go for an endoscopy, or quite reasonably didn't want to carry on going through an endoscopy, that they withdrew from the study. Next slide, please. Okay, our primary outcome measure, our most important measure for this was overall survival. And this is a Kaplan-Meier curve, which looks at the survival throughout the duration of the trial. And you can see that the two curves are almost identical. There was really no difference at all between the number of deaths in the surveillance arm and those in the at-need arm. Next slide, please. So this slide, again, it's a Kaplan-Meier curve, and this is looking at cancer-specific mortality. So here we're looking at cancer deaths, not just any death. Now, this measure does include all different types of cancer, and the reason that we chose this measure is that sometimes coding of cancer sites can be inaccurate. So even though the topic of most interest really is esophageal cancer, sometimes cancers can get miscoded, particularly if patients present with metastatic cancer that's spread to other parts of the body. and patients who have a cancer that may have started in their esophagus might have liver or lung lesions and therefore be coded incorrectly as a liver cancer or a lung cancer. And we wanted to make sure that we captured all of this data. So cancer-specific mortality, again, no difference at all in those Kaplan-Meier curves. The cancer deaths, 108 versus 106 in the two arms, really exactly the same. Next slide, please. Okay, what about a diagnosis of adenocarcinoma? So here, again, very similar numbers in the two arms, a slightly higher but non-significant difference in terms of the number of cases detected. So those who are having surveillance, we detected 40 cancers in the surveillance arm and 31 adenocarcinoma cases in the at-need arm. Again, certainly the concept that Barrett is going to be picked up at a dysplastic stage in the surveillance arm and treated to prevent cancer, it really doesn't look like that's working in this real world scenario. Okay, next slide, please. And again, if you could just click on one more time, please, because again, it's a busy slide. Here we're looking at the staging. There's lots of information on this slide, but focusing on those red circles, really the only point of difference was a slight difference between those presenting with very early stage cancer, the T1As, where you can see there were 9 in the surveillance arm and only 1 in the at-need endoscopy. That suggests that there may have been a tendency towards picking up those cancers at the very earliest stage. But that was not significant when we looked at the staging as a whole. So a trend towards picking up some cancers at the very earliest stage, but no significant difference there. And when we look at the really key things in terms of people's treatment and their prognosis, that's whether the cancer has spread to any of the lymph nodes or spread elsewhere in the body. And if you could just click on, please, then the red circles will move to the end staging, I hope. Yeah, thank you. So no difference at all in the nodal staging and the proportion of patients who had involved lymph nodes at diagnosis. And then if you can click on again, it'll move on to the M staging. And again, no difference at all in those presenting with metastatic disease that has spread. And those are the really crucial things in terms of stage that might affect somebody's treatment. Okay, thank you. If you move on to the next slide, please. Okay, and again, there's some red circles if you click on here. So surveillance is clearly better at detecting dysplasia. So in terms of trying to detect dysplasia, we're picking up more of it with surveillance. But as we've seen from our primary outcome and some of those key secondary outcome measures, it turns out that that isn't enough to really make a difference in terms of cases of esophageal adenocarcinoma, cancer deaths, or overall survival. Next slide, please. And again, if you click on once more, I think there's just a highlight that will come up there. Thank you. And one more time, I think it'll, thank you. So in terms of the number of endoscopies, exactly as you would expect, more endoscopy was, of course, done in those patients who are having scheduled endoscopy compared to those who did not have any scheduled endoscopy. There's one other statistic on there higher up, the patients who received no endoscopies. So 41% of patients in the at-need arm did not receive any endoscopy at all during the trial. For the surveillance arm, it's important to note that there were 7% of patients that didn't receive any endoscopy at all during the trial either. And there may be multiple reasons for that. And of course, this was analysed on an intention to treat basis, where patients would be analysed based on the group they were allocated to, even if they didn't follow through and have the endoscopies. Next slide, please. At the end of the trial, all of those patients in the at-need arm were offered an endoscopy, what we call an exit endoscopy at the end of the trial. And that exit endoscopy did pick up a small number of cancers. So there were 8 cancers in that group. There were also a larger number of patients with dysplasia who were detected at that time. If you can move on to the next slide, please. A cost effectiveness analysis was performed alongside this. Now, the cost effectiveness analysis was initially designed to see if the impact in terms of survival benefit was cost effective, but we didn't see any impact over that 10 years. So instead, we went on to do a study to see, to try and answer the question, well, we haven't seen a difference over a 10-year time horizon. Is it simply that we haven't measured over a long enough time? And if over a longer time scale, would we start to see benefit from these extra cases of dysplasia that might have been picked up if patients were having surveillance? So for this study, we assumed that the increased detection of dysplasia might translate into better outcomes. We had to make a number of assumptions around endoscopic therapy that's given for dysplasia and the improvement in survival. And we put this into a Markov model that then runs many, many simulations to look at those outcomes and try and predict what might happen in such a scenario. If you can move on to the next slide, please. So this plot here is looking at so if you look at the x-axis on the bottom, it's looking at the net monetary benefit overall, so the overall cost benefit of surveillance, and you'll see that's a negative value, suggesting that surveillance is not cost effective under these assumptions. And these are some fairly generous assumptions we've made to try to give surveillance the benefit of doubt, if you like, and seeing which of those treatment strategies is dominant in terms of cost effectiveness, whether at need or surveillance. And very clearly, surveillance would not be cost effective, even over that longer time horizon, using some fairly generous assumptions. Next slide, please. So key findings. This is the first randomized trial of Barrett surveillance. There's no other randomized trial that's been done anywhere in the world. It's the biggest trial that's ever taken place of Barrett's esophagus, looking at the number of patients and the length of follow-up. It's around 40,000 years of patient follow-up, so really a huge amount of work that's gone in, both locally and across the UK, with very many people who've been involved in this study and contributed a lot of work to it. One of the key findings is that low rate of progression to esophageal adenocarcinoma. So the overall rate of progression was 0.23% per patient per year, and that fits exactly with some of the more recent population-based studies that have suggested that low risk. Of course, there were significantly fewer endoscopies in the at-need group, so this strategy can reduce the number of endoscopies required and potentially be cost-saving. We found no survival benefit to surveillance, at least as currently practiced, over that 10-year time horizon. We know that surveillance does increase the detection of dysplasia, but this does not prove to be cost-effective, and those are our key findings. So in terms of how we interpret the data, if you move on to the next slide, please. I think it's important to comment that at-need endoscopy is not quite the same as no surveillance, in that all of these patients were given careful counselling at the start of the trial. And it's not quite the same as just saying, no, you won't have any endoscopies. They're told to get in touch if they have any symptoms that might be concerning. Many patients had gaps between endoscopies more than 2 years, even though they were scheduled to have them each 2 years. But this really does reflect just the real world challenges of surveillance and what we see in a real world setting when patients are offered 2-yearly endoscopy. We saw higher withdrawal rates in the surveillance arm, and that again reflects doing surveillance over many years. People get older, people develop other health problems, and might quite reasonably decide together with their healthcare provider that surveillance isn't appropriate for them anymore. Some of the other questions are, would better surveillance be any different? We talked about some of the challenges of surveillance, and obviously this study started in 2009. Things have moved on. Would we get a different result with better modern equipment, some of the newer techniques, if people were more closely sticking to the Seattle protocol and taking more biopsies? What if the surveillance was performed only in expert centres? Could we get better outcomes and results that way? Should we be doing even more surveillance? In fact, maybe 2 years just wasn't enough. I think the key point for me from our data is really that the low risk of esophageal cancer is the key, and that's probably the key reason why for this group who have non-dysplastic Barrett's and are at very, very low risk of progression, the endoscopies are just not sufficient to make a difference or an impact on that very small risk. Many of these patients are older patients who unfortunately will pass away within the time horizon of the trial, and they're dying from other things, and that's why the surveillance isn't having such a big impact. Next slide, please.
Got about 8 minutes left. I just in terms of time. Oh, sorry. There you go.
Okay, I'll skim through this. I think the conclusion from this is that we don't feel that we should offer regular endoscopy for patients with non-dysplastic Barrett's. All right, I'll move on so that Catherine can have her chance.
That's all right, and time goes away so quickly. Hi, Catherine.
Okay, could you jump through the next 4 slides, please?
1, 2, 3, 4. Step 1.
Next one, please.
Next one.
Thank you. Okay. So Ollie's explained the details of the trial that started in 2009 and the results from that, but that really wasn't the start of this project. It started considerably before that in terms of working out the study design, looking at the context which Ollie's explained at the time and the need for evidence in terms of the value of surveillance. Some of the things which were juggled with at that point were ethical considerations in terms of equipoise and bias, in terms of expected outcomes and so on. And as Ollie's mentioned, that it wasn't a case of either people had endoscopy or not, it was at need. So there was a caveat there in terms of support for patients who were in the control group. And then also the adjustment to the protocol as we went through, and we had interim analysis, and then we instigated the exit endoscopies at the end of the trial for the at-need group as well. Next slide, please. So in terms of the funding, obviously this was a large study over a long period of time and therefore was expensive to run. So in terms of applying to the HTA for funding, there was prior work with the HTA in terms of who commissioned a report to assess the requirements for it back in 2005, and then following that outline application for the HTA and so on. So and it's important to say this was led by Prof Barr and fantastically, and with Ollie's support, but a lot of other co-investigators were part of that initial collaborative team. And also working both with the trust here, who were sponsoring the trial, but then expert advice from elsewhere and input in terms of statistics and health economic analysis from elsewhere. So statistics were performed by the University of Oxford and health economics from the University of Glasgow. And then that led to the grant being awarded in 2009. Okay, next slide, please. So you've already heard about the start, the study and the setup and so on. So for us, in terms of delivering the trial, initially working with 109 sites, 109 nurses, teams working on that and so on, 109 R&D departments, not a mean feat to actually get that established, set up and supported throughout the trial. And then with the length of trial as well, obviously we had quite a turnover of staff during that period, so maintaining those contacts across the whole of the UK, the trial team did a fantastic job. I think the initial site initiation visits and making contact there, and then that ongoing relationship with the sites was really important, maintaining their momentum and so on. And yeah, next slide, please. So obviously we had governance structures within the trust in terms of sponsor, and then the other groups which were supporting the trial, so the management group looking at the day-to-day running, the steering committee and the data monitoring, which was external. And what I haven't put a great deal on here because it's standard practice, but really in terms of actually identifying who is involved in each of those groups was absolutely fundamental. And it was fantastic having enthusiastic people who supported the trial throughout and provided the relevant challenge and guidance as well. So in terms of designing further studies, I think it's really important to have that whole framework as a supportive network. Next slide, please. So the other important element in terms of study design was involvement of patients in the study design, and we were really fortunate to have a PPI rep as a co-investigator on the grant, so totally embedded. Obviously this is standard practice now, but looking back to 2005, 2009, that was probably an outlier in terms of the level of PPI involvement. Really important to have patients designing the research, being involved in that and so on. And obviously in terms of communication with patients, patients are best placed in terms of knowing how to pitch that and so on, and being involved in the steering committee with the ongoing delivery of the study. Next slide, please. So at the outset, an initial publication was made in terms of setting the scene in terms of the picture then of diagnosis and management of Barrett's, and that was really useful in terms of getting the word out in the community about the study and raising people's appetite for participating. Next slide, please. So then after that, we get onto data. So we had a huge amount of data, 3,500 patients, minimum follow-up 10 years. So the trial database was really important. And I think one reflection going back, that was managed in-house. I think probably looking at how you would design that and do that, and potentially with the statistics team being more involved with that, there would have been a cost implication of that, but I would suggest that would be money well spent. So the other things to think about over the period of time, the BSG guidelines were updated. So Ollie's already talked about people's compliance with Seattle Protocol and so on, but also in terms of trial protocol, and then being pragmatic about actually what compliance is going to be, what that actually means in practice and so on. And then we'll move on to discuss MRIs and DARs on the next slide, please.
Oh. Catherine and Ollie, I was just going to make a suggestion, and we've got literally sort of just over 2 minutes left. Obviously, we'll absolutely share the slides after the call, and it'll go up onto the website. But I was just going to ask, is there any burning questions anybody had having listened to it, listened to the presentation today? If that was okay, and I'll just stop sharing my screen and just give people a chance. We're down to 1 minute 55. Sorry, it's time goes by really quickly. But are there any burning questions? Ollie, you want to ask Ollie or Catherine on the call? No? Okay. It's such a lot of content here, isn't there? So Catherine, happy for you to carry. Oh, Marion, you've got a question. Okay, brilliant. Thank you.
Only a quickie. I mean, it was good to see that you had the patient involved in the actual design. One thing I would have quite liked, and you had obviously non-adherence to actually going through the surveillance for a group of patients, would have been really interesting to have got patient experience. What was it like for them against the two groups? Because it's not a pleasant experience, is it, having endoscopy and having them regularly? And I just would have been interested in that. That was a bit.
We collected all that data. I haven't included that in that short presentation. It's part of the cost effectiveness analysis. Quality of life was looked at very closely. The outcomes in terms of quality of life were almost identical. In fact, there was just a tiny, if you ask people about the endoscopy, on balance overall, people actually preferred that because they felt that they were being looked after.
Reassuring.
So there was a sort of a reassurance element to it, but that difference was absolutely tiny. But that was that. So yes, we looked at all of that.
Great, thank you.
Thank you. I just wanted to warn you all that Zoom kind of tends to cut you dead. It doesn't give you any warning. So, but unless it's kind of less than 1 minute to go. So I'm really sorry, Catherine, to kind of cut you a little bit short. But just to say, we will be recording it and we will be kind of promoting it as well. So I'm conscious, I don't know why, whether it's the weather and the heat. The attendance has been a little bit lighter today, but I'll perhaps get some feedback and make sure that people are getting the kind of communication that's going out, or it's just reflecting the